Good evening, everyone. Welcome to this evening's Lung Cancer Living Room. For those of you who may not know me, and I see a lot of new faces in the room, I'm Danielle Hicks. I am Chief Patient Officer here at GoTo for Lung Cancer. For those of you who aren't familiar with this programming, it was built with the person diagnosed with lung cancer and their families and caregivers in mind, where we bring to you live and in real time talks across varying aspects of a lung cancer diagnosis. Key opinion leaders like Dr. Velotta here. So Dr. Jeffrey Velotta is thoracic surgeon from Kaiser Permanente in Oakland, and he is no stranger to this meeting. He has been here before, and we had a wildly successful meeting and a really important conversation. So we're really looking forward to doing that here again tonight. Dr. Millie is on her way, so we are going to scoot her right in around here. But we wanted to get the programming started, so welcome to everyone. So tonight we're going to be talking about the role of thoracic surgery with medical oncology. A lot has changed, in the last half a decade or so. Particularly when it comes to earlier stage disease, but also in later stage disease, and some of the things that we're looking at from a surgical standpoint and what role the medical oncologist and the thoracic surgeon play together. What is your role as a surgeon?
So me as a surgeon, like just what Danielle said, like even the last decade, I would tell you the last year. I was here a year ago talking a little bit about kind of early stage and surgery, and then now you can see the topic already, right? Surgical options in all stages, right? So even in a year, things have changed like that. We're going to talk about today about other therapies other than just surgery, but in addition to doing surgery, which we didn't have. We'll talk to you about surgery, and we can tell you whether or not you need radiation or whether radiation may be better, or to see a radiation doctor, right? That's also an option, or whether or not maybe you just need to some type of systemic therapy with your medical oncologist or a combination. But more than likely nowadays, when we talk about anywhere from stage 2, stage 3-ish, and even to stage 4, it's a combination approach. Like you have to have your thoracic surgeon be able to understand the nuances of what medication may be the right thing to do with your surgery, because that's what we're seeing now. We didn't see that. For a lot of you here that even operated on, we didn't see that because that just wasn't those options. But now these clinical trials have produced good results. And so we are seeing way more thoracic surgeons now working with medical oncologists for pretty much every stage now. Right? The only one that I don't think everybody's totally gone on board with, and even no matter where you're at, whether you're at Hopkins or Harvard or Kaiser, it doesn't matter, is the stage 1A. Okay, so that means your cancer is less than 3 centimeters essentially, and you've had treatment. That is still, but there are clinical trials looking at that to have other treatments other than just surgery or a combination of surgery. So I think we're headed towards that. But then everything other than that, so stage 1B and on, now really should be with medical oncology. And I will tell you, that was not what I was talking about a year or two ago, that it was important. It was like, okay, if we operate on you, we could kind of take care of it, or your local surgeon in wherever, Santa Rosa, or wherever can take care of you. I would say no, that's not the case, because there's so many treatments even after surgery that you can get that you may not know that you qualify for, or we'll get into it, but biomarkers, right? And I know this is not a biomarker talk, but like that are still not getting biomarkers. So you really do need to have your medical oncologist on board with your thoracic surgeon more than ever.
Yeah, I agree. And I think, we know that lung cancer is an incredibly complex disease, particularly all the things we know about non-small cell lung cancer, which is where we're focusing tonight. And historically speaking, to your point, the job of the thoracic surgeon was to go in and cut out the cancer, right? And now, because of studies and trials and data and the information that we have and we know, we're bringing in medical oncology earlier in a staged diagnosis. Just because someone has surgery and the cancer has been taken out doesn't necessarily mean the cancer won't come back. I mean, the recurrence rate historically, without any sort of pre-surgical or post-surgical systemic therapy, the recurrence rates were pretty high, right?
Correct. And so we've always kind of known that the recurrence rate, this is anywhere, even for early stage, can be anywhere from 5 to 25%, right, for stage 1 within 5 years. And it's even higher if you have stage 2, 3, or 4 initially. And again, everybody's different. Everybody's different depending on, especially with personalized medicine. But generally speaking, yes. I mean, we were just talking about it earlier, right? Stage 1, went to stage 3. And that can happen. And that's okay, though. I think 10 to 20 years ago, I think we would have been, and some of you have been there that long, so you probably knew what it was like back then. Like, stage 3, oh my God, it's recurred, right? Now, we kind of know that. Like, we've always known that, but now we have things that we can do for it, right? We talked about that. The dual immunotherapy, right? This was literally just 5 or 10 minutes ago. So there's so many different things that we can do, whether it's immunotherapy, chemotherapy, or even targeted. Hey, Dr. Das, targeted therapy, which Dr. Das will go into. But there's so many other things that we can do for early stage disease to prevent that. But even if it does come back, because classically we watch early stage disease afterwards, that if it does, we are on top of it because we have biomarkers now. We know exactly what, and there's even these new tests that we can tell you what's your likelihood that you may have a higher chance of recurring or whatnot, even if you're stage 1. And so there's all these new things. And so so you need your thoracic surgeon because they operate on you. You got to know about, they have to know that we did the lobectomy. We know how you're going to feel. Are you having wheezy? But you need the medical oncologist to be ready right then and there. And so you're not like, oh my gosh, recurrence or whatnot, because that does happen. We all know that. The key is you just live, right? You live like it's diabetes and high blood pressure. You just live with it. It's not necessarily like, so I try to tell patients if they do have like a little recurrence here and there or whatnot, that there's so many treatments that we can do for now. And in a combination approach, right? It doesn't have to, it could even be surgery. It could be radiation. It could be chemotherapy, immunotherapy, targeted therapy, but there's all that. So many people like you all are living with that and you just live with it like it's a chronic disease. So I think that's really why I think it's so important.
Thanks, Jeff. And everybody, I'd like to welcome Dr. Millie Das, medical oncologist. And before we start, will you just tell me a little bit, or tell them a little bit about yourself, and then I'll kind of catch you up on where we are.
Sure, thank you. Sorry for the delay. My name is Millie. I'm a thoracic medical oncologist, practicing both at Stanford University and at the VA in Palo Alto, and it's really a pleasure to be with you all today. And one of my passions is clinical trials and clinical research, and really engaging with patients and talking about all the different treatment options. I think this is a very exciting time to be practicing in lung cancer, given all of the advancements and all of the new drug approvals that are happening. It's seemingly on a week-to-week basis, and so it's really wonderful to be working as part of a multidisciplinary team to really offer the best treatment options for our patients.
So, Dr. Doss, you mentioned multidisciplinary teams. Can you explain what that means to those that might not understand, and also talk about the importance of tumor boards?
Yeah, so I think when we think about multidisciplinary teams, we're really talking about engaging a lot of the different care teams to really individualize treatment plans for patients. And so when we think about tumor boards, which is a sort of a classic form of a multidisciplinary forum, we have our medical oncologists, usually several of them, specializing in thoracic oncology. We have our thoracic surgeons. We have our pulmonologists. They're typically the ones who perform the biopsies for our patients and can determine whether a lesion can be biopsied or not when we're reviewing that at our tumor boards. We have our radiologists, who are incredibly important. And even within radiology, we have a chest radiologist and we have a nuclear medicine radiologist, the radiologists who specialize in reading certain types of scans. We have our radiation oncology colleagues who are also determining whether something might be suitable for radiation treatment. So it's really bringing all of these doctors and advanced practice practitioners together in a room, virtual now. It used to be in a physical room, but now we're all meeting virtually to discuss cases that require multidisciplinary input. And so we're hearing from every different specialty and really trying to come up with the best sequence of events for a particular patient. If you can imagine at any given tumor board, they usually last about an hour. We're typically discussing 20 or more cases. So it's not that we can spend a whole lot of time, but we go through it. We're pretty efficient. We go through each case pretty efficiently. We work together so often now. It's usually weekly that we meet, that we can sort of anticipate what the other's going to say. But I think it's really important. It's not, you wouldn't go to a medical oncologist to get a surgical opinion. You really need to hear that from a surgeon. And so we do want to make sure our surgeons are there providing input. And then if we are recommending surgery, that if that patient is my patient that I'm seeing in clinic, I'm going to refer that patient subsequently to see a surgeon. And so this is where I think it just cuts down the time for our patients too, because we make these treatment decisions and then we can sort of direct patients in the correct ways rather than having them see everybody at different times, if that makes sense.
Yeah, it does. So, Dr. Doss, who should get biomarker testing and at what stage?
I mean, arguably everyone should get biomarker testing. I mean, I'm a big advocate for that. So regardless of stage, regardless of histology, but if you really want to think about the patients who absolutely should be getting it because it's going to impact their care, it's really patients with non-squamous histology that we're thinking about. Those are patients who are more likely to have driver mutations. Now, as we're thinking about some neoadjuvant treatment approaches, we're thinking, again, as Danielle mentioned, it used to be sort of later stage patients, all the non-squamous patients with stage 4 disease would get testing, but now we're testing patients with stage 2 disease. Anything beyond stage 2 disease, we should at a minimum be getting EGFR, ALK, and PD-L1 testing. But again, I would argue that we should be getting next generation full sequencing for any patient with non-squamous histology who's stage 2 and beyond. But in an ideal world, I think, we should be getting this testing done reflexively. So if the pulmonologist ordered or did perform the biopsy and the result comes back as any form of lung cancer, that tissue should get sent for the testing so that those results are available to the treating doctors. And because we just don't want to be behind the ball. We want to have that information so we can sort of move forward. If we're having to order the test, it only delays things. So I would say, I'm a big advocate for doing this, but as we know in the community, it's not happening routinely. And I think the other thing is making sure not just that it got sent, but that the results came back and someone's actually reading those results and interpreting them in the appropriate way.
Mm-hmm. Someone might be diagnosed with what we think, based on scans and upfront diagnosis, is a stage 1A or 1B. But it's not until your surgeon gets in there and can see what's actually going on. There's a potential for restaging. So some folks might actually have the biomarker testing prior to surgery, and some it might be, okay, now after surgery, we need to go back and now do the testing because since Dr. Velotta got in there or, your thoracic surgeon, you have been upstaged or restaged.
That's why I'd argue to try to just do it on everybody because you don't know what's going to happen. And sometimes even in these stage 1 patients, when you're hoping for cure with surgery or radiation, and if you do have a recurrence, you don't necessarily want to be doing it at that time, right? Yeah. Having that data soonest is best.
Yeah. Dr. Velotta, we're going to be using a lot of medical terminology today, particularly neoadjuvant, adjuvant, perioperative therapy. Can you explain what each of those terms mean?
So thanks, Danielle. If you have surgery, you can get surgery first up front. So if you hear surgery first up front, and then if you're a candidate for getting something afterwards systemically through targeted therapy, chemotherapy, immunotherapy, that's what you hear adjuvant therapy. Okay, so surgery first, and then if you have therapy afterwards, it's called adjuvant, like an adjunct, right? So it's surgery first, and then you get a little bit of something in your bloodstream afterwards, whether it's through a pill or through an injection. But if you do neoadjuvant, that's kind of where I think the really new realm is that you don't go to surgery first, and you have early stage disease like stage 2. And classically, we took all those patients to surgery. But now there's a big push because of these new findings that there's some maybe better results if getting something beforehand. So chemoimmunotherapy beforehand. So neoadjuvant means you get something systemically before you come see me. So when you do see a surgeon, you may need to see a medical oncologist, because if your surgeon doesn't know, or if their common practice is no matter what, stage 1 through 3, we're trained prior to all these studies to just chop it out and then you go see an oncologist and then they give you something, that's not the right thing anymore. That's changed. So the hardest thing to understand, and I think Jessica Donington, who will call it, because she's amazing, she's a chief of thoracic surgery at University of Chicago, she'll call it the sandwich approach, but the other term for that is perioperative. Perioperative, and these are some newer studies that have come out and I even have a patient, she may be online right now, she's getting it right now, and she just finished the perioperative. And perioperative just means that you get chemoimmunotherapy beforehand, then you get surgery, and then you also get some immunotherapy afterwards, and usually they try to do that for a year. That's the sandwich approach. So now you're getting it before and after, right? And so those three terminology, I think you have to know. And so perioperative is kind of the most complex one for most of us to understand. So if you think of sandwich approach, where you get it before and after, like just the double whammy, and that this is where we can maybe, if we get complex into it, like the differences of that, because there's so many different unique, that's why you need a tumor board. You may get 5 different opinions about which protocol to do and whether you should even do it afterwards. But I think that's the nuance here, is that sandwich approach. If you guys can start to remember that's out there right now, that and whether or not you or your family are candidates for that.
I've never heard it called the sandwich approach before, but it makes perfect sense. Like I can see it, you know?
I can't take credit. I gave Dr. Donington, who could be listening.
Yeah, but I think, and we're going to jump in now to sort of by stage and what this sort of looks like and what has changed. And Dr. Stoss and Velotta are going to talk about some of the data. Before we do that, I want to thank all the people diagnosed who have made the decision to join in these trials, because without you, we would not be where we are today, with the advancements that we know are having great impact on the lives of those who have been diagnosed after you. So a huge thank you to all those who participate. And Dr. Velotta talked a little bit about historically in the recurrence rate and what we have seen in this data by either the neoadjuvant, the adjuvant, or the perioperative systemic treatment is great improvements. Mm-hmm. So, Dr. Velotta, I'm going to ask you to start with 1A because that's typically you.
Yes. So 1A, the way we think of 1A is if you have a lung spot, one lung spot, and it's usually less than 3 centimeters. So, right, which is about an inch. An inch is like 2.5 centimeters. So if it's defined that small and it has not spread to lymph nodes or anywhere else, that's classically kind of like your 1A patient. So usually the standard of care would be surgery and or SBRT, which is kind of like a localized radiation. So again, that's not the talk that we're going to talk about today necessarily, but just know that there is an option that you have if you don't want surgery, or if you're, or if you don't, have a lot of medical problems and, and you're not able to walk or whatnot. So yes, there are, but classically it's local therapy. So you either zap the heck out of it, nuke it, right? Or you chop it out, right? That's classically stage 1A. There is currently no FDA approved or anything that we give before for those small little tumors. And so the idea is you treat it first, chopping it out, or you zap it, so with surgery and or radiation. And then this is where it gets a little complex. I don't want to get too into it, but generally speaking, we don't recommend or give things, and I'll let Dr. Das go into it, but we don't give things afterwards. However, I will say that's why I'm also like Dr. Dawson. We are 2 different doctors, 2 different systems, but I am a very big believer of reflexive testing for all stages because guess what? There is a clinical trial going on, and it is going on, and it's called ADAURA 2. And this is, again, no stake in the game, but this is looking at if you're stage 1A, taking a pill therapy if you have a targetable mutation called EGFR and doing that. And I don't know what that's going to show, and I'm not a representative for them, but just know that that's where things are headed. And there's even newer ones where they may start giving it earlier. And so if you look at other cancers, that's kind of what they've done, is either earlier the disease, like if you guys know breast cancer, the earlier before it's like breast cancer chop out, now it's like give chemo for everything. I mean, I don't know, I'm not about breast cancer, but I'm surprised the average like stage 1 giving, so I guess what I'm getting at is that stage 1, yes, I don't want to complicate it, you chop it out. But I do think, and I do this for my patients, and I wish we could say we could do it for everybody, no matter where you're at, but I do get biomarker testing now for that. That's a newer thing, but because you could qualify for, like we said, a clinical trial, and whether or not you need it, that's a whole discussion. And that's where you now need also, besides you don't want just me telling you about osimertinib and everything, you want to hear from Dr. Das about osimertinib and about the rash and about diarrhea and stuff. You don't want to just assume that I know it all, right? And so that's where we're even getting medical oncology involved even earlier. I'd say I'm a little getting ahead of ourselves, but that's ultimately where I think the future is. So you're going to even see us combine at the hip even more so. But again, I didn't want to complicate it, but I do want you to just know that, hey, look, even now
we're ahead of the game, and we're starting to look at the early stage.
Yeah, and there are clinical trials being done even at the 1A stage because we've seen so much improvement in some of the later stage. You mentioned reflex testing, and just so everybody knows, that's going back to what Dr. Doss said earlier, like, let's not wait and see, let's just do it, right? Let's just do the testing once a cancer has been identified, regardless of stage. So now I want to jump into the adjuvant space, which we've had meetings here in the living room specific to adjuvant therapy in earlier stage lung cancers, specifically stages 2 to 3C. Can we talk a little bit about what we learned and what's going on in that space?
Yeah, I mean, I think historically we've always talked about chemotherapy, adjuvant. So, so after patients with stage 2 or 3 lung cancer have surgery, they're referred to see a medical oncologist to talk about additional treatment after surgery. And we have a number of different options, and part of it does depend on the results of the genetic testing that's been performed on the tumor tissue and on the PD-L1 results. So we have cytotoxic chemotherapy. It's usually platinum-based chemotherapy that we offer our patients with stage 2 and 3 lung cancer after surgery. And then after the 4 cycles of chemotherapy, we have the options of immunotherapy and targeted therapies. And again, those options are going to depend on the PD-L1 status and whether a patient has EGFR or ALK. And because we do now have FDA approvals for osimertinib for our patients with EGFR mutations based on the ADAURA study, and for alectinib for our patients with ALK translocations, and that's based upon the results of the ALINA study. So both of these studies involved patients with stage 2 and 3 disease who've had surgery and then go on to get the targeted therapy. Typically, we're still thinking about chemotherapy for our patients and then thinking about the targeted therapy after that. For patients who don't have EGFR or ALK, we have FDA approvals for immunotherapy after chemotherapy, and that's usually given for a year after the 4 cycles of chemotherapy. And we know that the patients who have high PD-L1 expression, which is defined as greater than or equal to 50%, those are the patients most likely to benefit from that immunotherapy given adjuvantly. Though again, this is a discussion that we have. We always have to talk about risk benefits of all these different treatments and think about what that's going to involve for the patient. But these are the conversations. So after surgery, we hope to see our patients back to talk about chemotherapy, to talk about the potential for targeted therapies and immunotherapy.
Yeah. Can you talk a little bit about what some of that data showed in the trials insofar as recurrence rate?
Yeah. So particularly for our EGFR and ALK patients, we saw really a dramatic reduction in terms of recurrence, and also not just systemic recurrence, also recurrence in the brain, because we know that that can be a particularly devastating site of disease recurrence. And so both osimertinib and alectinib can get into the brain to prevent metastases from occurring in the brain. And so we saw pretty, I think, pronounced benefits with these targeted therapies and in the clinical trials, both ADAURA and ALINA. And these were data that were presented at major conferences, and people were very excited to hear the results. ADAURA in particular, we heard the data presented at multiple ASCO meetings and in the plenary session, really to standing ovation from the medical oncology community because of the sort of the excitement about the benefit that we're seeing for osimertinib in these patients who've undergone resection. And so this is now really standard practice. And in ADAURA, the osimertinib was given for 3 years, and that's really what the FDA approval is for that 3 years. The 3 years is somewhat arbitrary, though. And so many of us now, when we have these patients that we're seeing in clinic who've been on the drug for 3 years, we're having the discussions about, do you want to continue? Because we know that when you discontinue the drug, the chance of recurrence then goes up a little bit. And so, I think at some point in the future, my hope is we'll get to be able to track tumors through circulating tumor DNA, where we could do a blood test and then decide how long we should be continuing a therapy. For now, we're just sort of stuck with the way the trials were designed and the duration of treatment that was chosen for those studies. So in ADAURA, it's 3 years, but I do have some patients who say, I'm doing well on this drug. I don't really want to stop it. And we're able to get the insurance to authorize continuation. And so patients will continue for year 4, year 5. We also have approval for osimertinib in our locally advanced patients. I know we're not talking a whole lot about that, but patients who are getting chemoradiation for stage 3 disease, this was the ALINA trial that was presented at ASCO last year in the plenary session. Again, these are patients with EGFR who've gotten chemoradiation, and then they get osimertinib indefinitely after chemoradiation. Huge benefit compared to just observation. And so this is now also part of standard of care. So these targeted therapies we know can, have a big impact in terms of preventing recurrence and also delaying recurrence in the brain. And so this is what's exciting about the drug.
It's really exciting. So just to make sure that everybody understands, we're both involved in the treatment planning up front for this subset of patients. They come to you, they have this surgery, they recover beautifully.
Mm-hmm.
How long until they start a systemic treatment plan?
I mean, we usually want our patients to be fully recovered from surgery, and so typically the earliest is around a month after start. And but I think more typically between that 4 to 6 week window.
So when we're talking about neoadjuvant or before surgery, is it similar to the post-surgical or adjuvant type of therapy? And like, who's having these conversations? Are you guys having them together? Are you, whether you're at Stanford or at the VA or whether you're at Kaiser, is the medical oncologist and the thoracic surgeon in the room at the same time having these conversations?
I mean, Jeff, I don't know. Typically not at the same time. I think part of it depends on the referral pattern and if the patient's been referred to the surgeon, and then that's when the surgeon will introduce the idea of neoadjuvant and then make sure that the patient gets referred to a med-onc.
Yeah. So exactly. It's ideally, the ideal situation is you come in, right? And it's Dr. Doss and I, and like you have stage 2, right? Or whatnot, and in person, right? But that's never going to happen for now, so the reason why this is important, I think this is, now we're getting into the meat of it, like what I'm hoping that kind of the novelty of it is stage 2 and 3, okay? So generally speaking, for example, our tumor board that we run, and we run it once a week for our thoracic tumor board, ideally, in the ideal situation, no matter how many cases there are, now with the neoadjuvant, perioperative, adjuvant approach, all stage 2 and 3 should be discussed in a tumor board setting. Doesn't matter if you're 95 or if you're, 25, all of that should be, because are you gonna do surgery first? Are you gonna do chemoimmuno first? What's your biomarker? Did you just get EGFR and ALK? Right, or did you get the full panel? I don't want to complicate, but bottom line is that is important. So if you do, quote unquote, have, and it's usually clinical staging. What do we mean by clinical staging? That's complicated too. That just means based on basically your imaging. You get a CT scan, a PET scan, and the doctor tells you, I think you're stage 2. And maybe we did some lymph node biopsies and maybe not, right? And everybody does it differently. So if you hear those buzzwords, not stage 1 for sure, or whatnot, and it could be stage 2, it could be stage 3, you need to be presented in a tumor board. Because that's where, even though Dr. Doss or me, that wasn't in on your case, we'll be in the tumor board. And we may look, and we can tell a lot. So surgeons can tell a lot by imaging, right? And the doctor, whether it's primary care doctor, oncologist, or whatever that may, or pulmonologist, right? They'll be there too. Oh, that patient looks pretty good. So then it's all about imaging and what the next steps are. So just if you're presented in tumor board, that's good, right? And then because that tumor board will then recommend, maybe we think about doing chemoimmuno first, or maybe we think about just doing surgery first. And those nuances, that's where we're at right now. That is so complex. That will change week by week, surgeon by surgeon, medical oncologist by medical oncologist, for stage 2 especially. That is the most heated debate right now, right? If we were gonna be simplified, let's simplify it real quick, even though it's not simplified. Stage 1, you usually chop it out first, even stage 1B, even though maybe you could give something beforehand. Really, it's just chopping it out first, and then we'll see what you do afterwards in terms of what your biomarkers are and everything like that. Stage 2, that's 50-50.
Yeah.
The clinical trials do show some benefit, a little bit in the stage 2 patients when you break it down, but it's really the stage 3 patients. So stage 2, it's like maybe either way, you're gonna have surgery involved. You're either gonna do it before or after chemo or sandwich approach, right, for stage 2. Then stage 3, All right. So the thing that that I would focus on if I was like a patient listening to this, and again, this is all our opinions. Everybody's slightly different depending on who you talk to. But stage 3 is where it's really changed, where I think that absolutely you need to make sure you have a medical oncologist, a radiation oncologist, and a thoracic surgeon involved. Where I will tell you in the community a lot, they are still chopping it right out in the front. Or what I think is even worse is that they're just going straight to the Pacific trial, which is chemo rads and a year of immunotherapy, because that's what came out in 2018. That is the gold standard. Even in the NCCN guidelines, that's really what most people will do for stage 3 disease, not even offer surgery. And we still deal with that now, and this is in the Bay Area. So I think with stage 3, there's so many different options, but stage 3, I would say it's less common now if you have stage 3 disease to just chop it out or just get chemoradiation and not do surgery. Okay, that's where you need to have surgery involved. But most likely, the big shift and where all these new clinical trials came out was that in stage 3 disease, giving some chemo immunotherapy, assuming, again, that you're not EGFR or ALK, that's the whole different subset we're talking about. But that's a lot of other patients, right, that are not EGFR and ALK, that you should consider getting some type, if you're going to be surgical, to get some type of chemo immuno beforehand and not just to take you straight to surgery.
Stage 3 comes in so many different flavors too, right? And I think that one of the biggest questions that we always have for our surgeons is this resectable or not? And I think the definition, I'd love to hear from you, Jeff, I mean, the definition of resectability has definitely evolved as well, right? And so if we deem a patient resectable, that's when we really start thinking about the neoadjuvant or the perioperative approaches.
Correct.
If a surgeon really feels it's too risky to perform surgery, usually because of bulky lymph nodes or because there's just multiple levels of lymph nodes, then that's when we just completely change our treatment recommendation to chemoradiation and we involve our radiation oncology colleagues. But you know, what I've noticed is just that definition of resectability has really evolved over time. And I think as we think about some of these neoadjuvant approaches, I think we're even pushing the envelope a little bit in thinking about trying to make traditionally unresectable cancers potentially resectable. And I think and that's where our field is moving. I'm not suggesting that we need, we should be doing this, but it's just something because we're seeing such good efficacy of these neoadjuvant treatment approaches where we're seeing significant shrinkage of the tumor. So can we push that envelope and maybe think about taking out tumors that we wouldn't have traditionally thought about?
Yeah.
These are the things that we're doing.
And I think it is exciting and important to be talking about now. And by resectable, just so everybody knows, it means can it be cut out? I mean, that's what we mean. Can a surgeon go in and actually, get everything out? And that has really evolved. And thoracic surgery, I remember when my own mom was diagnosed in 2003, she had a thoracotomy. So she's got that big old wraparound, scar. And sometimes that still needs to be done. I mean, it depends on the complexity of the surgery, but the advancements in technology and surgery and the way we're even doing that now have come so far. One of the things I want to ask you guys, I think it's important that people understand the difference in surgeons too. There's cardiothoracic surgeons, there's strictly thoracic surgeons, and then there's general surgeons, and all of them can do this surgery.
I like you said.
But in my very humble opinion, and were it me, and I'm not speaking for anyone but me, I would want to ensure that I was speaking to a thoracic surgeon where this is all they do. They aren't also, doing open heart surgery and they aren't also taking out someone's, appendix. Like I think it's important. And there was a time when there were very few thoracic surgeon, like people specializing just in this type of lung surgery, and there's more now.
Yeah, I was laughing because the way you said it is right, because you're experienced, you've been doing this for 19 years, so you know how to guide everybody, but it is so different. Like all the stuff that I'm telling you, like it is so different. So you need somebody that really focuses on this. So classically, what Danielle's saying is true, that there's been a mix. There used to be a mix, like general surgery did a little bit, which they do everything. They operate on your appendix and your lung. And then there's the kind of like me, like just doing thoracic surgery, thoracic oncology, thoracic, like lung cancer surgery. And then there's the cardiothoracic surgeon, which I'm still a cardiothoracic surgeon, but you don't want me operating on your heart right now, right? And I would. You said you have a heart, I could do it, but you don't. That's not what I do. And I'll send you to a cardiothoracic surgeon that does just the heart. Now, there are cardiothoracic surgeons out there, and in California, and not just in rural settings, I will tell you, and this is not bad per se, but they do both. So one day they'll do your open heart, not chop you, but open you up. And then the next day chop out a lung, right? And that still goes on, okay? So that is what I think the nuance that we have to know. Nowadays you don't see as much the general surgeons doing that as much, even though you still may. I think what you have to know as a patient now is what's the difference between a thoracic surgeon that just does thoracic surgery, that they live and breathe whatever we're talking about right now, all the nuances, and we just look at lung or we just look at the chest and we don't do bypass surgery and whatnot, versus the cardiothoracic surgeon that does an open heart surgery but also does a little bit of lung. I think that I'm biased, right? I think not because the cardiothoracic surgeon can't operate, they can do just what I do, all right? It's not that they can't operate. They're technically gifted. They're all that, if not more so. The issue is what I find, and this is why the tumor boards are important. I'm on tumor boards in Hawaii and Washington and other places because they have cardiothoracic surgeons that'll be like, just tell me if I need to chop it out. Just tell me if they need a lobe or what they need to do. First, second, or third. They want it, but they want to know. Should I be operating? Should we give chemoradiation? Should we give chemoimmunotherapy afterwards? How should we stage that patient? The oncology part, right? So that's why it's not that they can't do the operation. It's like, just make sure if you do have one of those, wherever you are or whatnot, that they've done the appropriate oncologic workup, the staging workup, and then also discuss with you if you have the nuance of stage 2 and 3, or if you have 1B and you have EGFR, should you give osimertinib for 1B disease, things like that. So all of these crazy things, like they don't have that expertise because you can't. Trust me, I've operated on the heart before. If you operate on the heart, you got to be operating on the heart all day, and you're just living and breathing the heart, right? And so they can dabble in the lung, which they do. I'm not saying it's wrong per se. It's just they need some guidance. And if you have somebody that's giving them guidance, it's not the end of the world. I don't want you to say all cardiothoracic surgeons are bad because I have plenty of and she's not, but a lot of my colleagues are still doing that at the meetings. It's surprising. It's like, he's like, yeah, I did a lobe yesterday and then I did open heart. But I respect the guy. And I'm like, but I do wonder, right? Does he know everything, or he or she know about all the stuff that we're talking about the new exon 20 mutation that came out? And are you going to refer that patient, or should you refer that patient to medical oncology? That is so complex, and we're studying this day and night. So that's just something that we need to think about.
I think it's incredibly important. Does all of this sort of start over what we just talked about, stage 1 through 3C, with a recurrence and or a second primary?
Yes and no. I mean, I think it depends on when we think about a recurrence. And I think, Jeff, you were talking about this earlier. Like, if you have a recurrence, we can sometimes treat that with surgery again or with radiation. It doesn't automatically mean you have to get systemic therapy. So I think where you see the recurrence, how much there's recurrence, those all factor in. For a second primary, yes, I think those are tumors that we really just kind of start from scratch. And we know anyone who's had a lung cancer diagnosis, and even if they've been cured, and we have many of these in our clinic now, we know that they're at a higher risk of getting a second lung cancer. And we've seen that over time as well. So that's why screening is super important. We haven't talked a lot about screening yet, but screening, low-dose CT screening for eligible patients is really critical. And I think as a society, we haven't been doing a very good job. And that's something that we should be doing and focusing on. And certainly anyone who's survived lung cancer, we should be screening for another second primary.
I think that's important because I don't think that's something that people talk about enough. The screening in people who have already survived and or been cured from a lung cancer. We certainly know we're not doing enough in for those who have yet to be diagnosed. But I think it's even less in those people who are, for all intents and purposes, cured, and they just go on and live their lives. And we're going to run through the qualifying criteria, and the screening guidelines at the end of this. And I know we're running late, but I do want to get to the stage 4 because it is a question that comes up a lot. And I think there's movement here, and I think in a positive way. I know I just referred a patient in the UK to Jeff to at least have a conversation because things are also very different in other countries. But do you want to talk a little bit about stage 4?
Yeah, you brought it up. That's great. The simplified answer for you is that is still controversial, but yes, it's like kind of like when people start talking about politics. It's like, ooh, stage 4, right? It's that buzzword, but it shouldn't be. Okay, it shouldn't be, and that's why you need to go to these big centers that they have, whether it's a cancer big center or a Stanford or wherever, that people are thinking about kind of like innovative out of the box thinking, because there are trials ongoing right now for stage 4 surgery in stage 4. There are trials and studies already been done in Asia that are where we do see a lot of stage 4 and a lot of EGFR targeted for results with surgery. And then there's also us surgeons that have a lot of real world data. So what does that mean? Well, my patient, I just operated on her. She had stage 4. And yeah, there wasn't a clinical trial yet, but she's young or he's young or whatnot, and they're doing well. And then you start adding that up. And so it is a personalized, Millie brought it up perfectly. It is a personalized approach. The key is that not every stage 4 is inoperable, metastatic, brain, bone, everything. Stage 4 is so different. If you look at the new staging guidelines are so, like, now I can't even remember all, it's M1A, M1B, M1C, 1 organ, 2 organs, 3 organs, how many sites? Like, because there's a different prognosis based off of those things. So even if you're stage 4, that is changed. That is not like, okay, you're just a chemo patient. Don't see anybody else. The key is, it's not that I'm saying that every stage 4 patient needs surgery, but there's certainly patients that can qualify for surgery, and there's certain patients that are probably online that I've operated on and that can be here and that are still here because of surgery. Yet, do we have to wait for the clinical trials? The clinical trials are going to be there. They're doing it right now. But I will tell you, the places that are doing the clinical trials, which they've been revolutionary at MD Anderson and others, we have anecdotal evidence that rather than wait 5 or 6 years, some of us are saying we see evidence for doing it, and we do offer that now. So all I'm saying is, if you're in that situation, I do think nowadays you can reach out. There are people that won't just shun you and say, stage 4 surgeon, you need to see Dr. Das. They say, no, you need to see Dr. Velotta and Dr. Das, right? And that's part of it. As long as you see the medical oncologist, the radiation oncologist, and the thoracic surgeon in a multidisciplinary thing, I think that is where the future is for stage 4. I think that is very viable.
Well, and I think that's where the second opinions with doctors who have the benefit of specializing, right? Not everyone has that benefit, and not all medical oncologists only work in lung cancer. You know, general oncologists have to treat what walks in the door, right? And it's complicated, and it's the blessing and the curse, right? For those who can specialize, it's great because they get to go to the conferences, read the literature, learn everything there is to know about a disease, right? And I think that's where and why I continue, and this organization and others continue to push for second opinions, particularly if you're in a rural setting. And quite often, these opinions can happen virtually. You know, if you've had all of your diagnostics and your scans and everything's ready to go, that can be sent over to an expert who has the benefit of specializing, and then they can work with your doctors locally, right, to set up these treatment plans that are best suited for you. So it's so important in this era of precision and oncology and personalized medicine, where Dr. Doss, you said it at the beginning, you are each individuals. You can talk about median, you can talk about below, and you can talk about above, but nobody knows where anybody's falling on that chart. So it's so incredibly important. But thank you both so much for coming and having this conversation.
Thank you.
I know, how complicated it is. Those of you in the room, those of you watching live, those of you who will watch post live, don't hesitate to reach out with any questions you might have after this programming. If we can't answer them, we know who can. So all of you here in the room, those of you watching live and post live, the film crew for coming in, as always, hours before, making sure the lighting's good and the sound is good so that all of you at home can hear all of this important information. And then, of course, our supporters, and I am going to have to look down at the list for this. And for those of you who are regulars, it's because it's a long list. And that makes us incredibly proud, but also thrilled, because these folks recognize the value of this type of programming and information that we bring to the community here in the United States, but globally as well. So AbbVie, Amgen, AstraZeneca, Bayer, Boehringer, Ingelheim, Bristol Myers Squibb, Foundation Medicine, Genentech, Johnson & Johnson, Merck, Novartis, Novocure, Regeneron, Takeda, Oncology. Thank you all so much for your support. And until next time, thank you all so much, and we'll see you next month.
So I'll be brave if you're brave. I'll be brave, but only if you're